Hello and welcome back to the 2021 World Cancer Leaders Summit. It is now time for one of the summit's highlights. Dr. Atul Gawande is an American surgeon, a staff writer for The New Yorker, and author of 4 books, and he's a public health researcher, so safe to say he's a busy man. Dr. Gawande is going to be giving us some food for thought and share his perspective on how innovation can work for cancer control. Just a reminder, during the session, we want to encourage you to type your questions to Dr. Gawande in the question tab, which I believe is on the right side of your screen. But for now, over to you, Dr. Atul Gawande.
Many thanks for the invitation to be here. Of course, in 10 minutes, that's not quite enough to say a lot about cancer innovation. So I'm going to try to go to first principles here about how I think about it. We have come through an century of discovery. We have extended our life expectancy from, in high-income countries, from your mid-40s to, on average, 80 years or more for survival. Investments in breakthrough innovation has given us the innovations, the arsenal that's made that possible. We now have 70,000 different diagnoses, 70,000 different conditions that human beings can have, and we've enumerated those. We've developed more than 6,000 drugs and 4,000 medical and surgical procedures, plus hundreds of public health and preventive remedies that can be effective. And now our job is to deploy that capability town by town to every person alive. That is an extraordinarily complex endeavor. I've argued it is humankind's most ambitious endeavor, but our investments in breakthrough innovation have not been matched by investments in follow-through innovation. Hypertension, for example, is now likely our world's biggest killer. We have 1 billion people with high blood pressure, but only 14% have had it appropriately diagnosed and received the appropriate treatment to get it under control. Childbirth remains a major cause of death, and 99% of the deaths are avoidable with knowledge that we've generated. In my field, in surgery, and I'm a surgical oncologist, we have 10 million dead or disabled following surgery. Most of those are avoidable. Cancer care is no different, although it's sad to say it's less studied than some of these other areas. We have lower rates of incidence, but higher mortality due to lack of access to basic standards of safe and effective cancer care. Overall, lack of execution in delivering already existing medical discoveries is responsible for 1/3 of the deaths under age 75 in the US and Europe, and likely far more in low and middle income countries. And COVID, which we've just come through, brings home how these deep issues of failure to deliver translate into inequity within nations and between nations. Now, our traditional thinking in healthcare has been about how to create better delivery has been teach. We teach clinicians what's needed to be done. We've created rules and guidelines saying, here's how the system ought to work. But we've done little innovation around how to systematize. Compare that to think of traffic as an area where we've had remarkable innovation. We teach people how to drive. We enforce rules about how to drive, but most especially we've created a system of road and car design and rules of the road that have made it possible for people to fly by each other at extraordinary speeds with falling rates of death. And so our questions are, what are the rules of the road and our systems for cancer care? The approach we've taken at a laboratory I founded called Ariadne Labs at the Brigham and Women's Hospital and Harvard Chan School of Health has been to look at it in a very systematic way. We exploit the massive variation. In all countries, you will see that there are clinics and hospitals that vastly outperform others, even when they have the same resources available to them. We then study the outliers to identify key practices and design solutions that can achieve wide replication. So, for example, in surgery, our team working with the World Health Organization identified 19 key practices that were life-saving but being missed. They're primarily about communication and also about confirming steps for the big killers like infection, bleeding, and others those are not missed. The results from 8 cities in a trial of testing with major surgery, including cancer surgery, was a 47% reduction in death. We've developed methods then to drive large-scale adoption of deploying the checklist that enabled those practices to be followed, and we've developed methods to drive it into large-scale adoption, including systems for the systems included in the checklist for delivering the key drugs and technologies for safe surgery that are expected to be part of the basic checklist of delivering good care. And so since 2009, we've now confirmed where at more than 75% of all operations done in the world are with these systems of care. And from Scotland to Moldova to elsewhere, we've seen it replicated with double-digit reductions in deaths. I believe this kind of work is needed in cancer care too. We've had a focus on early detection and on the care that follows from that, and in the high-income parts of the world, but that focus on early detection in low and middle-income parts of the world has been questioned because of inadequate access to the downstream care, and not only that, also inadequate quality of care where people have access to the care. The innovations and systems that are required have to simplify increasing the safety and quality of care, and that has been a neglected part of our investments compared to ones we've put into follow-through care, but it is vital. I would argue that systems innovation is our next big opportunity to advance human well-being and health, but we've made a massive underinvestment. We still have a 20th century fixation on the breakthrough innovation in cancer without matching investments in driving the follow-through innovation that makes it simpler, less costly, and more effective to reliably deliver on very complex care across the spectrum, knitting together surgery, radiation, and chemotherapy treatments, as well as our preventive and public health approaches. But I believe that the investments in follow-through innovation and in our systems is beginning to change. Making delivery succeed will save more lives and reduce more suffering than any other line of work, I would argue. And in cancer care, that represents our major opportunity. I'd break that down into 2 core areas. One is in our ability to deploy our public health solutions and knit it together with primary care and the approaches for basic prevention and detection. But then there is also the work of downstream care and detection, ranging from basic systems for the surgical care in low-income settings, in district hospitals and the levels above that, for basic radiation therapy, and for cancer care. The work that has made it happen in other fields, whether it's hypertension, TB control, and COVID care, we've replicated in fields like surgery, childbirth, and even in palliative care and end-of-life care. We need to bring that much more widely to be full systems that are deployed. There are many fantastic examples that are deploying in different parts of the world. I've seen radiation performed in rural in parts of India where it can be done safely, effectively, with low-cost innovations and systems. There are many, many other steps along the way that we can be taking. Thank you.
Atul Gawande, thank you so much. It's so very, very interesting to hear what you have to say, particularly, I know we'll come on to this a bit more, this point about the difference between breakthrough innovations and follow-through innovations in care as well. But it's so interesting to talk about how we can advance cancer control equitably. And I know that our viewers have also enjoyed it. And for those who have missed it, what Atul Gawande has just been saying, his keynote will be available on demand on the Summit platform. Dr. Gawande, don't go anywhere, because we have received a good number of questions for you from participating leaders, and I hope you can spare some time now just to answer some of them. We've picked a few which seem the most relevant, perhaps, to ask you following your talk. So let me come to the first question. How do we introduce new innovations into different regions where different resources are available? So I guess the question there being, how do you introduce innovations into, say, lower middle income countries?
Yeah, for example, our systems innovation work in surgical care, I can give you some examples. Our trial that we ran was run everywhere from St. Mary's Hospital in London to Toronto General Hospital to University of Washington in Seattle to a rural district hospital in Ifakara, Tanzania, to Crush City Hospital in Delhi and Manila in Amman, Jordan. And principle number one was you have to have teams at each location that would be who own making it happen. There are lots of places where what you end up doing is passing a policy. Early on, for example, in the surgery work, it was mandated in Canada that every hospital adopted, but there was no implementation pathway that was created. Every hospital documented that they were following the regulatory law, but there was no reduction in mortality because that system wasn't put into place. By contrast, in Scotland, the key was making sure you had people on the ground who were prepared to implement. And we did the same thing, whether it was rural Tanzania or elsewhere. You need that team on the ground. The second is then you train the trainers, a very familiar thing to anybody who does public health work, and then around the systems of implementing it. But the third part was that each place has to modify the solution in order to make it actually fit into their environment. We had a standard checklist, but every single location ended up changing how they rolled out the checklist and how it flowed and worked. In Manila, for example, they'd have one nurse for every 4 operating rooms at the time we did the trial. And that was because every time there was a trained nurse, they would fully licensed and experienced, they get hired to the US or the UK. And so we had to use other staff to run the checklist in the operating rooms. And that meant, working with the hospital to identify who can walk through a 2-minute checklist with the team and make sure that everybody is having the real conversation. So, the long story short there is that it's all about creating innovation that can be deployed locally means building your network of teams that enable it to happen. But we now have thousands that we support through a network that includes anesthesia societies, surgical societies, and others. We've also deployed work that also lowers the costs of the technologies, and happy to talk about that if that's of interest as well.
Yeah, it's obvious that every setting takes multiple different factors in order to pull all the pieces of the puzzle together, I guess. A couple of more questions from our audience as well. One question is, you talk about systems innovation. Sometimes we have great innovations that can improve a service or a therapy, but they don't get scaled up. So how can we change this?
Yeah, the scale up part of it is what I just described to you is you have to commit to building scale. You have to campaign and create that campaign the same way, polio eradication is taking a 1950s technology, a polio vaccine, and making sure it's come to scale. And it's been a serious investment to enable that to happen across the world and get it to the point that we're within a breath of having polio eradicated. By contrast, we simply do not take that approach when it comes to our technological capabilities in care. We have professional societies driving the knowledge, but not driving the systematic ways that you can create adoption. So for example, one of the technologies that's made a huge difference in the safety of anesthesia is a simple pulse oximeter, the oxygen monitor that you put on your finger to monitor how you were doing. We found that in 2/3 of operating rooms in low and middle income countries or higher, that those devices simply did not exist. The companies that deploy those devices sell them and make their profit in the high income parts of the world and did not regard the low and middle income parts of the world as a viable market for them. So we founded an organization called Lifebox, which where we were able to raise just enough money to ask for bids on we created specifications for low-income countries where you had to have a different design. We wanted it to be simpler, more self-explanatory, easier to use, and have battery supply that could last at least 18 hours because of frequent power cuts in these environments. And then we put it out for bid saying that we would guarantee purchase of at least 10,000 of these units. And the result was we had 8 different companies that came forward. The winning bid was dropped the price more than 80% for low and middle income countries. And the result is that we're now 10 years in. We've now deployed, in fact, north of the 10,000 units. Training has been given. We follow up at 6 months and we see that they're in use and being appropriately used. And we have now more than 25 countries in sub-Saharan Africa, plus elsewhere, where we are at over 90% of the operating rooms supplied and the teams trained in how to use the tools. You have to build that kind of a effort and movement.
Yeah, it's an extraordinary achievement, and I congratulate you for that innovation and implementing it that alone. Another question, and this probably plays into what you've just been speaking about, Atul, but are there systems innovations best buys that could apply widely across different settings? This kind of thing with the oxygen box?
Yeah, it took it took a decade or more of work to really identify where the highest value work was going to be. When we created the World Health Organization effort around surgical work, we gathered people around identifying what were all of the innovations, or where were all the innovations that were out there that could make a big difference. Some of them were simple practices, like making sure you have got the protocols in place for people to follow. But then the others were some basic things like certain drugs, certain technologies, et cetera. And we then had to prioritize. We had to say which ones were the ones that had the biggest life-saving potential. And we started with a package of those. The Disease Control Priorities Volume, DCP3, which is been put out every decade or so from the World Bank, and I got to be part of, really lays out an effort to have that cost-effectiveness analysis. And in the cancer care area, there are some interventions that are clearly worthwhile, but it depends on whether you have the downstream systems in place. Early detection for breast cancer, for colon cancer, for cervical cancer are crucial, but then you also need to be able to have, whether it's the radiation treatment or the surgical treatment, available to realize the potential of that early detection. And so it's knitting these core components together and identifying what's the system that can be in place. We demonstrated on the surgical side that building a district hospital that could execute on 40 operations, including certain key tumor operations, were supporting that facility, that system, the cost of the staff, training, everything else, created as much value as making sure that some of our most important vaccines in the world were deployed. That notion that you apply that public health mentality to the system itself, we haven't laid that out in cancer care. What is that core of basic functions, not just specifically for breast cancer or cervical cancer, but a package of diagnostic capabilities and treatment capabilities that a district level hospital can make sure is widely available. I suspect that you could demonstrate what its actual value is compared to other public health interventions.
And just one final question to you, Dr. Gawande, and probably my favorite in its simplicity is, what innovations bring you hope? What are you most excited about coming down the line?
Honestly, it's, again, in follow-through innovation, the ones that have given me the most hope are the ones where we've decided that we are going to figure out how to make it happen. And COVID, ironically, as painful and difficult as it's been, has brought us more recognition of the inequities between countries and within countries, and then commitments to saying we're not just going to create, flood the world with vaccines. We're going to make sure that we have the innovations and systems that can create the cold chain, can create the delivery pathway from port to person, and that we have the tools to be able to not only do the delivery, but educate people about the value and address the resistance that there is. It is a Herculean task over the next 2 to 3 years, but the dividends that are going to come are going to pay off for every disease.
It's been an absolute pleasure to have you with us. I know that you're in Boston, white coat at the ready behind you. You're right on message. Well done. And you're going to be speaking to the annual meeting there in Boston as well, which we'll be chipping in on again over the course of this summit. Atul Gawande, many, many thanks. And thank you to our audience as well for taking part in that first question and answer session to Atul Gawande, the first live Q&A for this summit at least.